Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. Today in my lesson I am going to touch briefly on the topic decorticate and decerebrate process. And these are abnormal stereotype movements involving the trunk and extremities in the individuals with severe brain injury. Look at these pictures. This is the patient with decorticate posture, the one. There is extension of the lower limbs with flexion, plantar flexion of the feet, with interning of the toes, adduction and internal rotation at the hips. And the upper limbs are flexed, and there is flexion of the wrist, adduction of the shoulders with internal rotation. And the hands are folded onto the chest. This is decortical posture. Look at the decerebrate posture. There is complete extension of the lower limbs and the upper limbs. The plantar flexion of the feet, extension at the knees, adduction and internal rotation at the hips, as we have seen in the decorticate posturing. And in decerebrate posture, there is extension of the limbs at the elbow, upper limbs, adduction and internal rotation of the shoulders. Well, flexion at the wrist, as you see in the decorticate posture. Okay. Well, if you remember the spastic hemiplegia, that is the lesion involving the corticospinal tracts, which results in the extension of the lower limbs and flexion of the upper limbs. This decorticate posture can be similar to the double hemiplegia. Then what is the difference between the decorticate posturing and the hemiplegia? That is double hemiplegia as a matter of fact. The only difference is patient with decorticate posturing is in state of unconsciousness, where the patient with hemiplegia, they are conscious. This is because patients with decorticate posturing, that is, reticular system is affected, which controls the consciousness of the individual. Well, the decorticate and decerebrate process are abnormal responses to noxious stimuli, characterized by stereotyped movements of the limbs and extremities, and trunk. They were first described by Nobel Charles Sherrington in 1898 while he was doing experiments with the rabbits and rats. He cut open the brainstem and the animals presented with abnormal postures. These are symmetrical with bilateral involvement. When the injury is less severe, they may present with asymmetric involvement, sometimes decerebrate posture on one side, decorticate posture on the other side. They are mixed, sometimes inconsistent when the lesion is less severe. Well, lesions above the level of the red nucleus results in the decorticate posture, and lesions below the level of red nucleus results in decerebrate posture. Usually associated with underlying severe brain injury. That's why early diagnosis and effective treatment are mandatory to avoid mortality. So, what are the points to learn out of this lecture? When you find a patient with abnormal posture, it's all the way very important to physical examination findings to find out the clinical findings associated with these postures in order to know the underlying lesion. When the patient is in decerebrate posture or decorticate posture and in coma, take the distal history, look for the gaze paralysis by looking at the eyes, examine the fundus for raised intracranial tension in terms of papilledema. Okay, look at the other signs of inflammation and infection. Then we should also understand the underlying pathophysiology depending upon the etiology. Okay, and review the etiological factors by detailed history. Okay, outline the treatment plans and assess the prognosis. These are the points to learn when you come across a patient with these postures and listen to the lecture. What is the prevalence? There have been no published data related to decerebrate or decorticate posture. There have been reports on the pathologies. So pathologists have given a data related to their findings of the different lesions affecting the brain who presented with decerebrate and decorticate postures. Okay, out of which traumatic brain injuries are the commonest cause of these postures. That means decerebrate and decorticate postures are commonly seen in the patients presenting with traumatic brain injuries. Okay, as reported in 2019 a review report, it says there are 69 million cases of TBI in every year, associated with 7.9% classified as severe cases with GCS of 8 or less than 8. Okay, that means decerebrate and decorticate process are the commonest presentation of traumatic brain injuries. So let us learn about the various features of decerebrate and decorticate process. Okay, by which you can make a diagnosis that this patient is having decerebrate or decorticate rigidity. But remember, these processes do not tell you about the diagnosis. Saying that the patient is in decerebrate posture, saying the patient is in decorticate posture is not the diagnosis. You should evaluate the condition in the light of detailed history and the physical examination and the diagnostic workup. Then make the diagnosis, identify the cause which resulted in these postures. Okay? In decerebrate posture, what are the features? Lower limbs are extended at the knee. There is a plantar flexion of the foot with toes internally rotated, extension at the knee, both knees, adduction and internal rotation at the hips. Okay. These are the features of decerebrate rigidity, and patient is unconscious. The lesion is supposed to be at the level below the red nucleus. Okay. Below the red nucleus means it is in the brainstem. In the brainstem there are reticular nuclei. So it involves the reticular nuclei and the descending tracts, etc. Okay. Look at this patient in decerebrate rigidity. This adduction at the shoulder, internal rotation, extension at the elbow, forearm is pronated, wrist is flexed, lower limbs are extended. Coming to the etiological factors. Well, there are numerous causes of abnormal posturing, which may be grouped into supratentorial causes, infratentorial causes, or diffuse. Okay, and due to the lesion could be anything, but the presentation could be with decerebrate and decorticate postures. Along with the other clinical features related to the particular etiological factor. Supratentorial causes include abscess, hematomas, they could be subdural or extradural. Subdural, they are more serious than the extradural hematomas. Hydrocephalus, traumatic brain injury, which I told you, when associated with the diffuse nerve cell damage, is the commonest cause of these postures. Intracranial hemorrhage, raised intracranial tension, and tumors. Infratentorial causes include again abscess, tumors, infarcts involving the brainstem and diencephalon. Okay. Intracranial hemorrhage involving the cerebellum and midbrain, traumatic brain injuries, and hydrocephalus. Well, a point to mention here is when the lesion is in the central diencephalon, it presents with the features of decorticate rigidity. As the lesion is extending downwards, the patient progressively develops decerebrate rigidity. Okay? When the lesion still extends downwards, he develops hypotonia. That means hypertonic posture is turned into hypotonicity. Ultimately develops cardiorespiratory failure and death. This is the progression of the manifestations that develops when the lesion is extending from diencephalon down to the medulla oblongata. Remember this. Other group is diffuse metabolic causes, diffuse and metabolic. They include cerebral malaria involving obstruction to the microcirculation, secondary to the sequestration of the parasitized RBC, causing obstruction to the microcirculation in the brain. That results in the diffuse cerebral edema and neuronal injury. Encephalitis, electrolyte disturbance, especially hyponatremia, which results in the cerebral edema, hypocalcemia and hypomagnesemia, and hypoglycemia, which is very dangerous, hepatic encephalopathy, lead poisoning, and hypoxic ischemic encephalopathy are the other causes of diffuse metabolic causes. Well, let us consider anatomic basis of these manifestations like decerebrate and decorticate postures. Well, when we have seen the decorticate posture. What is happening in decorticate posture? There is flexion and adduction of the and folding of the upper limbs over the chest with flexion of the wrist. That means there is a flexor hypertonicity of the upper limbs and extensor hypertonicity of the lower limbs. That is in the decorticate posture. Okay. In decerebrate posture, what is happening? There is extensor hypertonicity of all the four limbs. Okay. Well, the lesion in the decorticate posture is above the level of red nucleus. Okay. What are the tracks that maintain our normal posture? Vestibular nuclear system with vestibulospinal tracts and the reticular nuclei and reticular spinal tract. They are excitatory and maintain the extensor tone. They are extensors. But their extensor property is checked and put in inhibition by the cortical fibers. That is corticospinal fibers. So they are in balance. Then we normally neither maintain extensor hypertonicity nor the flexor hypertonicity. We'll have the smooth, normal, voluntary act. Okay? When there is this inhibition is inhibited, that is, if there is disinhibition, there is unopposed action of the vestibulospinal and rubrospinal fibers, resulting in the extensor hypertonicity of the lower limbs. Okay. Well, there is flexor hypertonicity of the upper limbs. This is again secondary to hyperactivity of the extensor signals. As you see in the corticospinal fiber injury to the corticospinal tracts. For example, pyramidals and others. What is happening in the hemiplegia? What is the posture of the limbs in hemiplegia? That is, there is extensor hypertonicity in the lower limbs and the flexor hypertonicity in the upper limbs. Okay? But the patient is unconscious. Once he recovers from the shock, the patient is in consciousness. Okay? And the lesion is above the level of red nucleus. This is what happens in the decorticate posture. What is the difference between the decorticate posture and the hemiplegic posture? They are the same. But only difference is the patient in decorticate posture, there is bilateral involvement and the patient is in coma. Whereas in hemiplegia, there is a flexor hypertonicity of the upper limbs, extensor hypertonicity in the lower limb, but patient is in conscious. Okay, this is the difference. Well, whereas in decerebrate posturing, there is disinhibition of the vestibulospinal and reticulospinal tracts. Okay, and there is damage to the rubrospinal tract. Right? So that is the reason why there is extensor hypertonicity of the upper as well as the lower limbs. So this is the pathophysiology and the anatomical basis of decerebrate and decorticate postures. What is normal posture? Our posture is direct. We have got the extensors response to maintain the erect posture under the influence of vestibulospinal and the reticulospinal tracts. At the same time, it's not the consistent hypertonic posture what we have normally because of the inhibition of the reticulospinal and the vestibulospinal tracts by the higher centers. So that's the reason why we maintain the smooth, well executed voluntary movements. Okay. When this balance is disturbed, there could be the dominance of the extensor tone, resulting in the decorticate or decerebrate postures. Then let us touch on the decorticate posture. This lesion is above the level of red nucleus, with the flexor hypertonicity of upper limbs and the extensor hypertonicity of the lower limbs. This has already been described. What are the features? Lower limbs, plantar flexion of the feet with the turning of the toes, extension of the knees and erection of the hip and internal rotation. Upper limbs flexed at the elbow, arm pronated, folded onto the chest, wrist flexed and shoulders adducted and internally rotated. Okay, this is flexor hypertonicity in the upper limbs with extensor hypertonicity in the lower limbs. This usually symmetrical, but it could be incomplete or asymmetrical, associated with injury of less severity. So lesions, as I told you, are above the level of red nucleus. Could be in the diencephalon, okay? Could be in the midbrain, above the level of colliculi. Well, what is the neuronal pathway to get these movements and the posture when the patient is subjected to noxious stimuli? So when you give a painful stimulus to the body of the patient who is lying down flat, he will suddenly develop these movements associated with extensor movement of the lower limbs with flexion of the upper limbs in case of decorticate posturing and diffuse hypertonicity, extensor hypertonicity of the all the four limbs in decerebrate posturing. Okay, this is very painful really. The stimulus you are giving is carried by the spinothalamic tracts to the center. And there is a voluntary command from the cortex to the lower centers via brainstem, cerebellum, and finally to the spinal cord. Okay, that results in the abnormal posturing of the limbs. As the etiological factors we have already described for the decerebrate rigidity, they apply to the decorticate rigidity also, like trauma, like vascular lesions, infections, tumors, etc. Well, having known the features of these postures, having known the detailed history, okay, diagnosis must be rapid in order to proceed with the treatment. Take the MRI scan of the brain. It shows the lesions. It could be supratentorial or infratentorial. It could be lesion associated with the decerebrate rigidity or the lesion that results in decorticate rigidity. Depending on the level of the lesion and type of the lesion, you can confirm the diagnosis and proceed with the treatment. When there is obstructive lesions and space occupying lesions, surgical evacuation is going to give tremendous recovery. Surgical evacuation of the central hematomas, good response. Treatment of infections like brain abscess goes good improvement. Correction of metabolic errors like hypoglycemia, excellent, and is attended to early. And correction of hyponatremia and other metabolic disorders results in good response. And proceed with the shunt surgeries for hydrocephalus. And following treatment, subject the patient for rehabilitation and physiotherapy. Okay. Well, prognosis depends upon the is it decorticate posture or decerebrate posture. Patients with decerebrate rigidity, they have 60% recovery stage, whereas decorticate posture is associated with 37% of survivors. This is one of the reports. In traumatic brain injuries with decerebrate presentation, mortality is very high. That is to the extent of 78 to 80%. Those who recover, they suffer from physical and intellectual handicaps. Well, when the patient is younger age, less degree of trauma, early institutional treatment, recovery rate is good. Extradural hematomas do better than subdural hematomas. Yes, this is one finding. Well, thank you very much, my dear students, for patient listening. We'll meet you again in the next class. Until that time, bye-bye.